This is LiveWell Talk on stroke care in the ER. I'm Dr. Dustin Arnold, Chief Medical Officer at St. Luke's Hospital, Unity Point Health. When it comes to stroke, time is essential. And today joining me is Dr. Ryan Sundermann, Medical Director of the Emergency Department. And he's going to discuss signs, symptoms, as well as the essential treatment and of treating an acute stroke and what the symptoms are and what may happen after you arrive at the emergency department. Now, Ryan, I know typically in the month of May you celebrate National Vinegar Awareness Month. And this year, stroke is also Awareness Month is also in May. Are you going to celebrate both?
I don't know if that was a typo or if that's just your eccentric knowledge of weird facts.
I know how much you enjoy vinegar. And so you're going to do both.
Yeah, of course. Why not?
All
yeah,
right,
so
good.
that may be at my house. I don't know if we're going to celebrate vinegar here, but
Yeah, keep that. Let's keep that at home. I love our place. Well, first, let's start. What is a stroke?
There's several different types of stroke. Typically, when we refer to the standard strokes, it's a blockage of a blood vessel, basically. We could get into as many details as you want, but as you know, there's like people have heard of like cholesterol and plaque and things like that, and those exist within your vessels. And typically, one of those kind of flakes off and creates an injury inside the vessel, and the body attempts to heal it. It creates a little clot, and then that clot then blocks that blood vessel, and then the blood stops flowing, and then when the brain doesn't get blood through that vessel, it starts to die or get damaged. There's another type of stroke, which is when you blood vessel breaks, and that's called a hemorrhagic stroke, and that's considerably less than the number of those are fewer, but they are still considered a stroke. It's an injury to a vessel in a brain that causes poor blood flow to that area of brain and leading to its death.
Sometimes when I'm asked that question, sometimes I say it's a heart attack of the brain.
Yeah.
Because I think
sometimes people think heart attacks and strokes are the same thing.
But I mean, I think people understand a heart attack and a heart attack of the brain, and time is important. Now that we understand what a stroke is, and the listeners, at least they have that concept, the next is to diagnose it. Mm-hmm. And for the general public, there is an acronym, am I correct, that they can use to at least run through the symptoms they may be having and determine whether or not it could be a stroke. But as I know you say this and I say this, if you think it's a stroke, just come to the ER. Right. Don't try to second guess yourself. But what is that acronym?
So it started off with FAST, and FAST was something that was developed for the public to use. You maybe even saw some of the billboards that used to be out on, and the paramedics would sometimes use it. And that was just face, arm, and speech that were the big ones. And so if you had facial droop, if your arm wasn't working, or if your speech was slurred, or you couldn't talk, find words, etc. And then they changed it to B.E.F.A.S.T, which is a little bit more in depth because, so for example, balance, when people come in and say, so B stands for balance, eyes, and then FAST, the face, arm, and speech. The problem with balance is that people come in and say they're dizzy. And that can mean a lot of things. Off balance, lightheaded, we always have to differentiate that. But for the general public, if you feel like you have new onset of dizziness, lightheadedness, something that you're not accustomed to, then those certainly can be signs of stroke, especially balance issues. And so those can sometimes be accompanied by like spinning or, also lightheadedness. But if the balance is off in coordination, that kind of what it gets to, because in the formal FAST score, that often got left out. And, again, without getting into a whole bunch of details, a different part of the brain kind of controls your balance as opposed to what controls your face, arm, and speech. And then eyes also, if you have vision loss, sometimes a stroke can be just vision loss.
Yeah, blind,
There's a special word for that called amaurosis fugax, which we don't use very often, but I know you love your Latin.
I do.
So there's that was a term we don't use, but that's just sudden vision loss, and that can be the sign of a stroke as well.
And also it can be sudden speech loss.
Right, absolutely.
I saw a patient with Dr. Barnett, the cardiothoracic surgeon, when I was a medical student.
Yeah.
So that's like the early 90s, right?
Yeah.
And it was a lady had a stroke. It was an embolic stroke, right? From an atrial myxoma. And her deficit was she couldn't speak.
Yeah.
So she gets up around her house, and she lives by herself. She's going all about her stuff. And then she goes to call her friend, and she realizes she can't speak.
Yeah.
So that was a very unusual presentation. Yeah. And I think that reinforces that strokes can be an unusual presentation.
Absolutely.
And people should have a low threshold. If they're having brain symptoms of any sort, they need to come and be seen.
Yeah, that's what I tell people. You wouldn't need me for, the standard chest pain. Like if you're having chest pain and you can't breathe and you're sweaty, you could probably just walk up to the cath lab and get your cardiac cath. It's the weird things. It's the unexplained sweating. It's the nausea that you've never had before. It's the really weird left elbow pain, things like that for heart attacks. But with strokes, they can be very sneaky, the vision loss. And sometimes the vision loss, people they can still see straight ahead. They don't realize that it's actually kind of out in their periphery, and that's why some more detailed testing just on physical exam is important, because they can tell something's wrong, they just can't put their finger on it. But then when we come in and put them through an organized stroke screen, we'll pick up some of those subtle details that and once you point it out, then they're like, oh yeah, that's it, and then you can really pick it up, and then that's when you got to get them to the care that they need. So,
well, speaking of getting them to the care they need, we mentioned that time is essential, or of the essence,
right?
At the beginning of the opening. So how much time, talk about the time factor here.
Yeah, so obviously every minute counts. I mean, the clock really is ticking as a general rule. So I'll start off by saying, the time that we figure is when it starts is your last known well. So unfortunately, people wake up a lot of times with stroke-like symptoms, and so their last known well was when they went to bed. So that's why it's important. Like if you wake up in the middle of the night and you feel like something could be going on, don't go back to bed hoping it's gone by morning, because that's just more time, So if you really feel like something's going on, come in. But ideally, we get people in here within 3 hours, because most of the research that's been done that looks at the use of some of the medicines we use to break up the little clot that blocks an artery in stroke, the evidence that is out there really best supports that medicine to break up that clot is given within the first 3 hours. They've stretched it out to about 4.5 hours, and so we'll still do it in cases. But once you get to about 4.5 hours, there's not a lot of great evidence to support giving any kind of medicine to reverse the effects of that stroke. So that's kind of the time frame. But I don't want people to say, I'm going to wait around 90 minutes because I know I got 3 hours, because that damage is being done. So every second counts.
And also, each case is unique.
Yeah.
And, I know in your career, I've given it at 6 hours, depending on what the situation is,
right.
And that the risk is starting to outweigh the benefit at some juncture there. But because now, when you talked about medicines, for the listeners, that's a clot busting drug that dissolves clots. Mm-hmm. And not only does it dissolve clots in the brain, it dissolves it head to toe.
Right.
And so there is the risk of bleeding.
Yep.
And there's criteria that you follow, evidence-based criteria to give that. But one question I want to ask for myself is age still a contraindication? Or
so that's the thing.
At one time, it used to be really hard and fast. Like, okay, there's
85.
70, there's 72.
Nope. Yeah. But now, every case is unique, like you said. But anymore, the thing is there seems to be a lot of benefit, especially with like heart attacks, for example, like cardiac cath. It used to be, if they're over 80, we're not going to take them to do a cardiac cath. And now we've learned that those patients actually benefit most from it, And so I think every case is unique, but there's really not a lot of age limit, except we have to really, on the stroke scale, there is something, I think it's 85, right, that says, and that, it's not an absolute contraindication. So there's a lot of discussions that have to go on with the family about what they are willing to take on. I believe the number is still 6% risk of bleeding for any time that you administer TPA. But if you've had other bleeding risks, like if you've had a recent gastrointestinal bleed, if you've had recent surgeries, things like that, those are all important to take into consideration prior to giving the medication.
I'll say my clinical experience, I find patients they would rather take the risk of having bleeding and dying than having a stroke and be left with a deficit.
Yeah.
They don't want to be a burden on their family, and they're like, let's do this. Now, the patients arrive at the ER, you suspect is a stroke. How do you confirm that?
So confirmation is actually kind of relative. So the thing is that a lot of times when people come in, and we do the CT, that's the most important thing, is we get the CT scan. And so people are assuming that we're confirming there's a stroke on that CT scan. And what the general public may not realize is what we're really doing with that CT scan is confirming that they don't have a bleed, because if you've bled into your brain, you definitely can't get something that makes you bleed more. So if you've had a hemorrhagic stroke, that's an absolute contraindication to getting TPA, obviously. And so that's the biggest thing. However, with some, and I don't know if you're going to get into this maybe a little bit later, but like with some of the newer CT scans, we can do what's called a perfusion scan that fills the vessels with some dye, or they call it contrast, and that helps us get a better idea of how large the stroke might be. But as far as
now, I'm familiar with that technique, but I'm not I haven't looked at a lot of them, and I know you have. Is it pretty definitive? I mean,
when it's definitive, it's definitive.
Okay.
The problem is when it's not.
It's like
not.
a nuclear medicine test. Like when it's definitive, it's obvious.
It's obvious, right? So the thing is that when we get the regular CT scan, most of the time it's not going to show much of anything. Sometimes in a big vessel, they can actually see a large clot or hemorrhage or something within that actual vessel, and that person needs to get intervention immediately. But then they can also do some of these perfusion scans, and what they do is they look at the actual area of infarct, which is the area of like true damage, and then they look at the area around it that might have a little bit of blood supply coming from some vessels surrounding it, and they look at the ratio of that true infarct to the area around it called a penumbra, and they look at that ratio. And that ratio helps them determine the total size, but then also the ratio. Because if you have a small area of infarct, but then a lot of area that's being damaged but isn't dead yet, that's an area that's amenable to further treatment. And so that's why it's important to get in here, because that's what's salvageable at that point. And so that will show up on these perfusion scans that we do now. I would say the confirmation is actually an MRI that they would do the following day. But really, we're doing those initial scans to help know whether or not this person is eligible for TPA, and then it's based off their signs. So if they don't have a bleed and everything else about it says stroke, then they're eligible for TPA. So it's more the exclusion of the hemorrhagic stroke and the confirmation based on your physical exam.
And then once the diagnosis is made, then they come to the hospital medicine service with the neurologist. Mm-hmm. Do most strokes end up in rehab, or how do most people do that?
Yeah, I guess unless they turn quickly around. So, and that's the other thing about TPA. The studies that showed its benefit are actually people kind of assume you give this TPA and the next day you wake up and you're like tons better because you get the TPA. Actually, the evidence that they collected from that looked at 30-day outcomes. So people, if they get better in the next 24 hours, they assume that's the TPA. Well, it could just be that your body broke it up itself. Yeah. And most of the evidence would suggest if you get better in 24 hours, you probably would have gotten better anyway. A lot of it looks at functional outcomes at 30 days from the TPA, and those are better if you give the TPA. But that is, so you don't just wait around to see if you're going to get better from the TPA. You need to be doing everything to make sure that if you have ongoing symptoms, that the brain is fairly plastic and it has some ability to kind of restructure itself and make new connections, and you can retrain the brain, and that's a lot of the therapy that goes into play. So whether it's speech therapy, functioning with vision loss, functioning with a balance problem, and learning what you got to do, and some of it's safety issues, some of it's swallowing, for example. So one of the first things that we do in the emergency department before we give you any medications is a swallow study to make sure you're not choking on things, because that can be very subtle and that can lead to like unforeseen problems. You get a pneumonia because you had a stroke. People don't think of that. And so a lot of the therapy begins right there. And physical therapy isn't jumping jacks and push-ups. It's, things like balance and walking with a walker and, stuff like that. So,
this is just kind of a observation. I used to say that people don't die from the stroke; they die from the pneumonia, the GI bleed,
hip fractures.
They die. Yeah, hip fractures. They die from the complication, not necessarily that. Now, one thing that I've observed, and you maybe have seen this in the ER, but okay, so you get in, you have let's say your right side's paralyzed, get the TPA, and it gets better, and you're like, awesome.
Yeah.
So I make rounds in the morning, it's better.
Yeah.
Well, then the nurse comes in and the patient demonstrates to the nurse it's better. Then therapy comes in, demonstrates it. So by late afternoon, those muscles are fatigued, and the patient's like, "Oh, my stroke came back.
My new weakness." Yeah.
So I always try to educate people on that when we first put them in the hospital, that you may see that happen.
Yeah.
And then it's not such a shock when it's then the next morning it's back to where it was. So, prevention is the key to everything. And we can do a whole other podcast on how we miss the opportunity to prevent things quite often in healthcare. But what are some of the risk factors and those risk factors that can be modified for having a stroke?
Well, smoking. Those are their 1, 2, and 3. I mean, absolutely do everything you can to quit smoking. Just as a side, kind of my strategy, if anybody needs a strategy for quit smoking, the 1st and 15th, quit. People need to practice quitting smoking. Don't do it the first of the year every year when people tend to, and like, I started smoking again. quit as often as you can, so twice a month, quit smoking, go as long as you can. So, it's 1 day, 2 days, don't get discouraged. If you start smoking again, 2 weeks later, you do it again. So
you know what I used to do to patients? So you smoke, let's say, a pack a day, 20 cigarettes.
Yeah.
I'd say, okay, you smoke 20 for 3 days. Then you smoke 19 for 3 days.
Taper down, yeah.
Then you smoke. So even if you are getting ready to go to bed and you're supposed to smoke 7, but you only smoke 5, you got to sit there and just drag them and just till it's done.
You got to make them hate
it.
Yeah.
So it gets to the point that you get it. I'm getting this medicine, this drug I'm addicted to out of my brain.
Those are definitely, and I think it's all trial and error, because there's no one, if there was one proven system that worked, it'd be out there, and that's what everybody would do. So that's a great way to do it. And I tell people, quit smoking, change the way you drive to work, because people are very habitual about their habits. They drive the same way, they take the same walk, they have their coffee. Change up your whole pattern during that day. Take a different route to work, so you got to be paying attention to road signs and things like that. Hopefully not looking at your phone, but and then do the Nicorette gum and the lollipops, chew on pencils, suck on lollipops, all that stuff. Go as long as you can. If you start smoking again, don't be discouraged. Just do it again, over and over and over and over again. And over half the people that try that method will succeed in smoking cessation in about 9 months, I think. So.
I would say that, if you're trying to lose weight and you're adjusting your diet, right, and you fall off of it, you have the cake. And then you say, well, I fell off it today. I'm just going to eat the rest of the day. I would say, okay, if you drop your cell phone, do you jump up and down on it? Or do you pick it up?
Right.
And just stay with it.
Don't beat yourself up.
Yes, absolutely.
Yep, because nobody's perfect. It's hard. Smoking.
No smoking.
Yep. Diet and exercise, obviously, those are big ones. There's a genetic component to it. If everybody's seen, George Burns, he smoked cigars his whole life and he lived to be 103. Nobody knows who George Burns is anymore. But there's those guys that lived a lifestyle that was not conducive to, stroke health and things like that. And then there's the 40-year-old guy who runs, 6 miles every day, and he has a stroke just because he was born that way.
Right.
So you can't get away from your genetics. You can get genetically screened for it, but the things that are easy are, you don't smoke, you eat right, try and avoid saturated fats and all that. And actually carbohydrates, I know carbohydrates are the new fat, right? So there's a lot of evidence to suggest, especially processed sugars are very inflammatory. And the thing about plaques that rupture that cause heart attack and stroke, because the mechanism is the same, that little cholesterol shell inside a blood vessel has got, they call them spongy macrophages, and all it is a bunch of really inflammatory cells that make that plaque amenable, it ruptures and it flakes off, and when that does, that's what creates the injury inside the vessel. So you got to stabilize that plaque, and so one of the best things you can do, and the simplest things, is limiting your sugars, because they found that simple sugars create this inflammatory, from insulin and things like that, and by cutting your sugars, it helps stabilize that plaque. But then also things that stabilize plaques are like statins, for example. And the thing about statins, as you probably know more than I do, is that statins aren't just normally they don't just lower your cholesterol, but they're actually anti-inflammatory. And so that anti-inflammatory component is a big deal. So if your doctor says that you should take a statin, and you don't have any side effects, because there are some people that statins don't work for them. For one reason or another, but if you can be on a statin, those statins are critical to prevention, and that's one of our inpatient goals, is making sure we get them out of here on a statin. I don't do inpatient medicine, but and then exercise, and so prevention, either before or after a stroke, talking with your doctor and make sure you're cleared and it's safe for you to be in a program. But then doing that regular exercise, which not only is weight control and things like that, but it's actually anti-inflammatory. But it also, when you exercise, you cause your heart rate to go up, your heart rate beats harder, and what it does is it creates more flexion. So if you normally just walk around and your heart beats, your vessels kind of pulse, just like you can check your pulse. When you exercise, your heart beats harder, and that actually creates more, and that stimulates elasticity or stretch of your vessels. And so it makes your vessels actually healthier simply by exercising. And so there's a lot of benefits to exercise other than simply weight loss and calorie restriction, things like that. So smoking, good diet, and exercise are critical.
Yeah, I always use the analogy of a unloaded revolver. That's your family history, right? Then you start putting smoking, high blood pressure, diabetes, high cholesterol. Yeah. Now you have a loaded gun that's very dangerous. Yeah. And so we want to keep that proverbial gun unloaded.
I love your analogies.
Yeah, I know.
Yeah. Full of them.
I am full of them. I'm full of something, that's for sure.
Yeah.
Ryan, this has been great information.
Yeah.
Once again, this is Dr. Ryan Sundermann talking to us about strokes and preparing to celebrate National Vinegar Month, as well as National Stroke Awareness Month in the month of May.
I'm not sour on Vinegar Month.
Again, this is Dr. Ryan Sundermann, St. Luke's Emergency Room Medical Director. For more information on stroke care or any other medical topics, visit unitypoint.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe, and if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.